Welcome back. So this next panel is called Beyond P-Values, Applying Precision in Research to Emergency Medicine. And I'm happy to introduce, I'll just give her a second here, give the system a second here to bring her in. We get so impatient with these things, but it's really amazing how this all works, isn't it? That we're all in multiple disparate areas and somehow it's all coming together and we can see and talk to each other. And if it takes more than 15 seconds, we're all completely disgruntled and out of sorts about it. So I'm happy to introduce a colleague from Stanford Emergency Medicine Department, Maya Yadom. She is our vice chair of research at this point. And one thing that I've already learned about Maya, just in the short time that I've known her, is she's able to cut through all the noise and static about a question or a topic and just distill it very succinctly into a very digestible and understandable format. So I've already come to appreciate that quality about her, and I'm happy to learn more too. Maya, I'll let you take it away from now.
Well, JC, thank you for that very kind introduction. This is absolutely my pleasure to be part of the StEMics conference, and then in addition to be moderating this panel that includes many friends, colleagues, and people whose work and practice ethic I admire. We'll be talking about Beyond P-Values, applying precision to research in emergency medicine, and I couldn't think of a better group to talk about what things have been, where they are, and where we see things going. And so just to tell you a little bit about myself, I'm a clinical operations researcher, mostly in cardiovascular disease. Spent a lot of time working with new clinical trial designs that are enabled through the electronic health record. And my personal training has spanned from the period of time where we were all using paper charts to when we were figuring out how to grow our own electronic health record systems and then use commercial products most effectively. And I've now not only used electronic health record systems and other data collection systems to collect and have data as repositories for what has happened in the past, but try to figure out how to take that information and feed it back to help us understand the likelihood of certain disease diagnoses, as well as responses to treatment. And there's a lot of work going on by individuals you see here, trying to figure out what that means for new clinical trial designs, study designs, information gathering, and even the way we practice care. And so without further ado, I'd like to introduce the individuals that we have here on the panel. I'll start with the first person at the top on my right, Dr. Jonathan Chen. He's a practicing hospitalist here at Stanford University. He uses software engineering to build computational infrastructure, designing rigorous algorithms to permit him to analyze and interpret clinical results from multifaceted perspectives to enhance effective design and the implementation of next stage clinical informatics development, really all affecting the care that we practice. He's involved with the National Academy of Medicine's report on artificial intelligence and machine learning in medicine, has translated that to his experiences in practice and research, and co-chair of the 2008 Symposium on Human Artificial Intelligence in Medicine. He's somebody who I have enjoyed working with and developing methods and practice and thinking about what research can be. And many of his collaborations span from general medicine, statistics, quality improvement, computer science, as well as emergency medicine. Next on our panel is Katharina Schultbrox, who is an assistant professor at Columbia University, where she is also the director of computational medicine and artificial intelligence in the Department of Emergency Medicine. She's a trained clinical psychologist with a focus on methodology and data science. She has expertise in statistical methods, but even beyond that, predictive analytics and causal modeling. And her primary area of research is to distinguish patterns of psychiatric risk and resilience based on individual differences in people's biology and algorithms, and taking known knowledge of a patient, taking new data that's collected from them in the course of care to understand how they'll respond after interfacing with our clinical care environment. And last but not least is Dr. Kenrick Cato, who's a nurse researcher and assistant professor, both in the Department of Informatics at New York Presbyterian's Hospital at Columbia University. And he's also in the Department of Emergency Medicine, working closely with Katharina, as well as some other colleagues we have in emergency medicine. He has a varied background. He worked in the hospital system as a surgeon nurse and as an analyst in the information technology department, working on projects to improve patient safety through the use of clinical decision support, which is often one of the tools that's used to influence care through informatics and analyzing the data available to us. His current program of research focuses on mining electronic patient data to support clinical decision-making. And he's been NIH funded, has worked with many collaborators, and I believe emergency medicine is really pleased to have him practicing both research-wise and applying his knowledge in our space. And so with this fantastic group, I'll just pose an initial question to get our discussion started. First, understanding where we've been and where we're going, what are some of the tools and methods that are driving change in precision-oriented emergency medicine research?
Dr. Yadam, do you maybe want to just call us in order? Is it this big nebulous things? I think there's so much that we can all contribute to just doing it the most systematic way.
Absolutely. So Jonathan, since you're speaking, let's go right ahead with you. And from there, we'll see who's ready to chime in.
Uh-oh, wait a minute, I got called out first. That's fine. One of the broad themes that interests me, I think bridges a lot. I certainly actually resonate a lot with emergency medicine. I do general medicine. It's the kind of thing like, there's no necessarily elective case, right? You have to handle whatever walks in your door, and that could be anything and everything. And maybe 100 years ago, one doctor could know it all and could do it all, because the reality is there wasn't that much we could do anyway. Advances in science are amazing. Now we have so many treatments. We have thousands of medications, thousands of diagnostics, but that also means that complexity is completely out of control. It's completely unrealistic that we can do this just with their unaided expert human minds. Computational informatics tools has to be the way that we tie things back together. So some of the tools that now are possible, a lot of these ideas aren't new, but it's just having the infrastructure of, say, the electronic medical record 20 years ago just didn't exist. The ideas aren't new, but now it's become possible to pursue those, study them, track them. I'll go into more detail in a bit, but now working with Christian Rose in the department right here, and also our postdoc, Marteza Noshad, in collaboration with Vinny Liu at Kaiser and Julia Adler-Milson at UCSF, we're studying the access log data. You don't realize this, 4,000 clicks a day in every ER shift, but also every time you touch a computer, the computer's actually recording what you're doing, basically. You might not realize that's what's happening. This is more for like security purposes. But the irony of that, we're so stuck on the computer, also means it's one of the most useful tools to monitor and track our behavior, to understand our workflows so that we can best improve our processes and thus care for patients. So that's one area I think would be a very cool area to develop and gain new insights from.
So I could go next. So I think that Jonathan talked about the clinician, the patient, and one of the things that when you look at Columbia Emergency Department with Bernard Chang, who's our Vice Chair of Research, we're very focused on thinking about the clinician and clinician well-being, things like burnout. And so all of the more advanced computational methods that you think about when you think of machine learning, neural network learning, deep quote unquote deep learning, we are thinking about how we can learn about the environment of the emergency department, how we can learn about clinician characteristics to help give clinical decision support back to the clinician to help them do their job better. So for example, there's Dr. Chang has a R01 right now where we're actually looking at the EHR log data that Jonathan was just talking about, and also looking, clinicians are actually being monitored continuously for 2 weeks at a time. And we're applying different surveys, and we're looking at their level of burnout and thinking about how their interaction, all of their interaction with the patients, interactions with other clinicians, and also their interactions with the EHR, and how that affects ultimately the clinician and then back clinical care. So that's another area that I think you see people doing more of in this space.
Yeah, and I would like to add on exactly like this interaction of, as Jonathan said, using, for example, electronic health records, which are, of course, they have a lot of benefits, but a lot of challenges also to deal with. And they have the benefits of being routinely available, but to make use of them, we have a lot of missing, a lot of biases in this kind of data. So I think the biggest, what we saw so far, there are a lot of benefits of using machine learning, but the quality of the data we have is key, and without that, it's like difficult to draw any conclusions. Also, to implement this, to really close the translational gap between the research and then also the clinical implications. but also like what Kenrick just said, the interaction of the value information of the clinician. So when a clinician is concerned how he interacts with the EHR, we can use this information, as Kenrick just said. But there are also like a lot of new technologies using wearables or other technologies in the ED as in combination with, for example, information from electronic health records or other routinely available information.
And that brings up a really good point. You know, many of our data systems that capture the care we provide to patients were designed for just that, to capture the care provided for patients. And we've been able to see how focusing on patient records and their information captures how we are working outside of that system by the touch and the contact we have with it. But what we use the information to do, whether it's ordering prescriptions or it's planning a procedure or it's number of times you go into a record, as a sign of maybe a patient's acuity, or maybe the opposite because you're not there directly at the bedside. And so I think these secondary elements of exactly how the EHR reflects secondarily what we're doing in the care environment is an area that I don't think was part of what we expected to be using these systems for. And so with this new use case in mind, a lot of you are working with the record and finding where it's short, and how if we really are studying the phenomenon of care delivery and how people are using care and what care they're receiving, we probably need some adjuncts and other tools and other things to help us advance the precision of the care that we're delivering. And so how can we study that more effectively? What should we be doing with our systems or even in our practice to help us cross that bridge?
We'll just do a standard rotation. Tell us we should change direction. Sure. That's a big, difficult problem. I mean, it's the classic approach for decades is that can't you doctors just like fill out your chart as a bunch of checklists and checkboxes? That would make it so much easier to do the data analysis. And of course, there's like riots when you try to make clinicians do that. And it's intolerable, right? You're trying to just take care of the patient in front of you. Doing this very structured data entry can be actually quite limiting. So then you say, well, let's do different techniques to address missing this, do some natural language processing, try to extract things out to get some more information out of it. But I would take that acknowledging some of what Ken or Rita brought up, like these are just not research data sources. They were never meant to be. There's still a lot of useful information and value in them, but they shouldn't be treated as if they were a purposely designed registry or cohort. And if you try to draw strong causal inference conclusions from it, you're almost certainly going to be misled. But that means maybe we should just ask different kinds of questions from them. What is the normative, most common behavior chosen? And what is the typical outcomes? Not necessarily drawing causal conclusions, but that still can be very valuable. I try to relate it to one of my main threads works is recommender systems. Like, I don't necessarily know what is good or bad, but just tell me what do most other doctors do in this situation. That already is actually very informative and very useful, but I'm still a human being, right? I still have to integrate that, combine the best of that computational tool with a human-based reasoning applied to an individual case, and don't expect the computer to have the answer, but instead of 10,000 medications and diagnoses I could choose from, computer, could you narrow that down to the top 10 that fits in this usual situation? That is actually still a very powerful and useful approach.
Fantastic response.
Yes,
yes. Do you want to go, Carrie?
I would just like to add on to this because I completely agree, and I think there's important discrimination between explanations, so like causal inference, or just like maybe also how can we use this data for other purposes, for example, risk stratification, which is I think the ED provides such a unique opportunity, but also challenges, but it has the opportunity that, especially in my area where I'm focusing more on the psychiatric risk after acute medical emergencies, this is usually the only contact for a long time patients are in contact with the healthcare system, and ED clinicians are also important to plan, okay, what are the intervention that should follow, and that's why I think like it has the benefit for early risk stratification to better decide, okay, who needs what kind of care at a second step. For example, when we also think about like prognostic enrichment of, for example, also RCTs, which could help us in like research to better improve, okay, for whom might be a treatment like more beneficial than for others, etc. I think all for this, we could use these information also collected in the ED.
And, you know, there are two areas also I'd like to add. I think, so some of the work that I do is, I do a lot of work around risk stratification for deterioration, but I think it really ends up being interdisciplinary communication, trying to use machine learning methods to understand, to kind of model what the expertise of the clinician and what they're thinking about the risk of the deterioration for that patient based on their interaction with the EHR. So for example, you know, in the ED, you'll see sometimes that nurses who are interacting with the patient more than the physician, for example, will increase their surveillance of the patient by taking more vital signs, entering more information, and modeling that and passing that information in form of clinical decision support to the rest of the team, that maybe this is a patient that the nurse is more concerned about. Because one of the things that I think we still lack, or one of the things that we can still improve upon, is interdisciplinary communication. So I think there's a role for these methods to do that. The other thing I would add is there are, you know, in the previous panel, somebody mentioned that patients move between settings. They don't live in the ED. And so something that I think a lot of researchers are starting to think about is multiple data sources and how we can incorporate and understand that individual patient. There's some really interesting work that people are doing. You know, for example, there's a paper I just read the other day by Zhang where they're actually looking at just the influence of weather on predicting cardiac arrest in the ED, and looking at other data sources. And that's kind of a more exotic example. But when you think of all of the data that exists out there about a patient, there is actual work being done from an infrastructure standpoint, an interoperability standpoint, to get some of the other things that other data that are living in other places, in the fire department and criminal justice system, in the nursing home and social services, all of those data in the outpatient setting to help provide support to the ED clinicians to take better care of that patient.
And this is really critical. The idea, we often think about the data we enter, but for any individual patient we care for, they usually touch a couple different information systems. You know, one of the easy targets, you know, in emergency medicine is getting the EMS run reports. How do we incorporate that into the resuscitation story for an individual patient, particularly those who are sick, or when there's information from the field that's communicated to EMS but not directly to us, or to us via EMS, where that gets documented. Vital signs in the field, EKGs in the field, and doing, as someone who does research that crosses those boundaries, there's a lot of data inconsistency, but we've become more sophisticated, and integrating that data, finding it and merging it is a challenge. So as we think about how do we reconstruct the care that patients have experienced, and how do we follow their care through different settings, I think it does challenge the way that we've initially set up our systems, but opens up opportunities for how those of us looking at this information and thinking about how it influences research can be part of the build conversation. Along those same lines, we're also learning that EHRs are used for financial reasons and, you know, billing reasons and information transfer and communicating with payers just about their patients as they look for how to manage risk, and also to look to how to manage health over a continuum that extends before and after the hospital. And I know there have been many people who've been savvy with looking at the way that data gets trapped and sent, and how we can use that to facilitate study designs. Now, just as an example, some of the work that I've done is involved using EHRs to randomize patients who've been discharged from the hospital by using business finance reports for who has a completed care event ended or submitted, and using that to drive a randomization scheme for a clinical trial that really were randomizing patients to a different outpatient care process. And so that's a unique way that we sort of bent what the system was built for, to enable a pragmatic randomized clinical trial. So very traditional, a new spin on a traditional study design. But I'd like to then reach to the panel and say, have you all had experiences where you've thought about how to create new methods or explore new methods, or even refine existing methods by using your knowledge of how the EHR is constructed to think about advancing a different kind of science? And maybe I'll go around Robin and start with Jonathan Chen.
Sure. There's a lot of elements there. The deliberate randomization actually would be the ideal, but it's kind of setting that up. There's a lot of infrastructure before that's going to be really realized. But I think in some of the, I actually remember COVID studies in the UK really demonstrate the power once you do that. I think there's also a lot of opportunity. The ER and a lot of the hospital setting, there's often a natural opportunity for a lot of pseudo randomization because it often is, it's who is ever on shift. That's who you got. So it's a lot of like processes and characteristics. You say, do they make a difference? We can take value of. Although having said, I think Ziad Obermeyer had a fun little paper that said ER physician assignment to a patient is not actually random because you look at who's on the board and you're like, no, I don't want that one. I'll wait for somebody else to take that one. So it may not be as random as perhaps we might imagine it would be, but understanding those processes is what we can learn a lot from. I mean, here we're doing the study of this access log data and trying to understand the workflow, all the different parts and pieces and who touches what in diagnosing a stroke, for example. And on paper, there's a protocol. Everyone has a swim lane, doctor do this, nurse do that, pharmacist. It's a very orderly, deductive flow of sequence of events. You look at the actual data flow, it is not like that. It's spaghetti, basically. There's all this interaction back and forth, but without being able to understand and model that, how can you understand what's actually happening on the floor and how to optimize and improve
it? Thank you for that. Henrik or Katharina?
Yeah, so what I would say is that there is work, there are that that the EMR has brought to our setting and positives, but I do think there is the opportunity to actually do randomization through the EHR. And a colleague of mine, Jason Edelman, who does a lot of quality and patient safety research, he's been looking at the wrong patient and wrong order or wrong prescription writing for a while, and he's found a way to actually build into the inherent clinical decision support rules that are built into the EHR to do randomization. And so I think we could see more of that. I would also say that something that I've been a proponent of for a while, and it's difficult to make it happen, but this isn't new, but simulation and synthetic modeling is a way that we can do a lot of research. I have a colleague at Columbia, Vishal Misra, who does a lot of synthetic modeling. It requires a lot of data, but it is a powerful tool. And so I think that is something I'd like to see us do more of actual simulation modeling with the data that we have, and compare that to what's actually happening, and then build clinical decision support around that.
And that sort of leads into one of the questions that we currently have, which is, it says one of the biggest issues in emergency medicine research has been about subject recruitment and management. Is there technology coming to make this 10 times easier? We need to quantify this 10 times easier in the future and to open up new opportunities. We've talked about randomization, but even taking a step back to subject recruitment, perhaps we can comment on experiences, but also knowledge from other groups' research.
Yeah, so I actually do have thoughts about that. So I come to it from a different direction. So I've been doing, I think one of the things that we can do more of is phenotyping for cohort discovery. And research that I've been doing actually is phenotyping certain cohorts where you can't necessarily get the information in the EHR. So for example, transgender individuals, phenotyping transgender individuals so that you can identify who they are, because they might not actually disclose that information in the setting, in the emergency department, or the clinician might not feel comfortable asking that information. And then you're able to then, one of the issues we have with certain populations like transgender populations is that the studies we have now, the same people end up in those research cohorts, right? And so you can have more representative samples. So I would say that folks that think more about applying actual phenotyping to do the actual recruitment, but also there are tools that are being built to help. it's interesting. I'm working on a project with Operation Warp Speed, where and you know, COVID has changed the rules for lots of things, but federal government's actually helping to fund better recruitment tools just so they can study COVID, so that you can have you can build into a build recruitment tools into the EHR so that the recruitment criteria can run on the existing clinical data, and clinicians can know that there's a patient here who either fits from a symptomatic standpoint or a diagnostic standpoint. So that is something that is being worked on right now as we speak, just for COVID symptoms, for example.
And that's I think a really enlightening perspective, that we're often thinking about building models and predictive approaches and screening to get patients with diagnoses, but even just for the potential to be eligible for a study. We do it for the potential to be eligible for a treatment. But I think that there's a level of sophistication that actually involves some simplicity of looking at it for this particular purpose. And so I think as you're reflecting, Dr. K, there's room for creativity and expanding what you've had some experience with one particular group, but there's lots of potential. And so one of the things, you know, we've been talking about is how the understanding the electronic health record is creating new avenues and opportunities for research. But informatics and also the work that all of us collectively amongst other colleagues are doing is actually changing our practice and what emergency medicine may look like in the future. I'm wondering if you can comment on that, and maybe I'll reverse the order now, Jonathan, and start with Katharina and then to Kenrick.
So how the future will look like. So I think there are like some important steps. So first of all, I think, so I'm a fan of machine learning, don't get me wrong, but I think the hype of machine learning is like long ago. And I think we now are in the phase of more scientific maturity, where we have to be more careful how we can use it and how can we test it so that it's usable. But I think the benefits still, when we think about the ED research and the information we have available in the ED that we could use for improving precision emergency medicine, I think the benefits definitely outweigh the challenges. But I think because of when I think about my area of research, it definitely has a lot of opportunity to reach the patients at the point of care. But I think we also need to think about new ways how to stratify not only looking at electronic health records or other information, but also of other ways of identifying patients at risk. And I talked with a few colleagues about ideas of using more digital phenotyping approaches, for example, digital biomarkers, like other ways how to describe the clinical phenotype than just using the information that is, as we just discussed, used not only for research purposes, but just for routine clinical care. And I think like for that it's so I think it will influence but I think we have a lot of steps in between. For example, that we also heard that in other sessions today, there is a big need of data sharing, that we have more diverse data, that we build a better algorithm that are also generalizable. We need to improve. I know there are a lot of engineers will tell me that's already possible, but we need to have a better real-time feedback of the available information, and also discuss always with clinicians, with patients, to better get feedback on how to implement it, that it's really usable in the ED. So in my area of research at least.
So, you know, there's just so many ways, Maya. It's such a we could have a whole day talking about the future of emergency medicine and how artificial intelligence, machine learning, informatics is going to affect it. So just very quickly, you know, I want to point out Dr. Schultebrook's research, especially looking at the sequela of, or the eventual development of PTSD diagnosis or symptoms, and she has a really great paper on that, but I think the implications of that, it's going to affect So right now, there isn't a lot of support telling an ED clinician what's going to happen to your patient, 3 months from now when they leave. So I can say this safely because my wife is an ED clinician, but I think one of the things that ED clinicians like is the fact that they see the patient and then the patient leaves, right? And sometimes they come back depending who they are, but one of the ways I think AI is going to change ED practices is we're going to be able to say to you, based on what's happening in ED, this is what's going to happen to the patient, a couple weeks, couple months down the line. And as an ED clinician, you have to think about that more, right? I think that's a major way it's going to change emergency medicine. So that's something to think about. Also, there's a lot of continuous monitoring research at home, especially with geriatric patients to predict falls. And you're going to see patients coming in because their machine told them that they're going to get sick, or the machine called the caregiver or sibling and said they fell. And so I think there's going to be more connection to that pre-hospital setting that you talked about, Maya. Those are the two major ways, but there's so much other stuff, computer-aided diagnostics and things like that. But I'll let Jonathan, add to it.
Great. I mean, there's so much going on. I actually really like a quote that Kurt Langlois gave at that if you want to do, cutting edge research, it's going to be like in a journal. If you want to actually affect patient care, you have to use 10-year-old technology. It's just kind of the inertia of the system, some for legitimate reasons, but also many other cultural ones as well. So what does that mean? If you actually want to things that affect our practice right now, that there are very valuable things, but it's like using an automated checklist or template. I mean, that's probably how I've helped most of my trainees. I just, a pulmonary embolism, you're not the first person to treat that. Just follow this list of stuff to do and just do that. And oh, wow, that's a very valuable information tool to have. Other way to think about that is you want to guess, well, where does the future of medicine going to be? Well, kind of just look at other industries that are doing very cool things in their industries. And in 10 years' time, that's probably those types of analogies can start to arrive in medicine. If you want to zoom in specifically on potential risk stratification, predictive modeling, machine learning applications, a framework I try to think around it is processes that are actionable, arbitrary, and ascertainable. Right? It has to be some kind of outcome that you can actually verify, otherwise you can't predict anything. It has to be actionable. It has to be something you can do about it. And also right now it has to be arbitrary. It's specific to a human. Like this patient with a pulmonary embolism, should I admit them or can I send them home? Right now, it's just me as a human being, right? Or you as me, you touch them, you look at them, it feels okay. No, this one feels worse, right? And we're actually, as human experts, we're actually very smart and can do a very good job of that. But expertise is very difficult to reproduce, which means that it is essentially impossible to deliver it consistently at scale without some kind of support system. Support, say, like risk modeling tools, even something as simple as a PERT score, but you can imagine how much more the infrastructure now exists that we can do that on a much broader scale with many more applications.
Now, these are fantastic comments that really tandem with a few other comments that were mentioned in some of the panels earlier today. One is the idea of thinking ahead, and if we're defining our specialty, and this is up for debate, but if we're defining our specialty as really focusing on acute and unscheduled care, it really refocuses what our intent is. We're trained in order to handle whatever comes in the door and be able to manage the first hour to 8 hours, depending on where you are, of whatever that might be. But I think we're being pushed to think about what about the next step? And to what degree the risk that comes into our emergency departments can inform risk for what happens in a subsequent healthcare encounter. I think there's a lot of value in our care environment to provide information to guide the next best step. Now, is that what we want to do or not? But I don't know. But that's a question I think that we're empowered to answer. And perhaps it is 10 years into the future. And then the other idea is, Jonathan, you're absolutely right, that when we're thinking about how do we impact care now, we are thinking about 10-year-old technology. And so we can either take the opportunity to look backwards at what tools are actually in practice that we can utilize to make change, or think ahead 10 years about where we could be going and start working on that 10-year use case. And so I'll maybe wrap up our session now. I see that Dr. Lowe has joined us. So Jason, thanks for coming back on stage. This has been fantastic. As Kenrick had mentioned we could talk about this for hours and perhaps have a full day conference on just this. And so I appreciate everyone hanging with us as we talk about research for precision healthcare, delivering the right care for each patient at the right time in their course, and how to think about this beyond just p-values and chi-square tests, but really about the methodology that drives the practice we're looking to have in the future. So thank you for your time.
Thank you all. This was fantastic. It really makes us think maybe we should be having a separate conference just on this topic alone, right?